Hi friends, so now we are starting off with general pharmacology. So in this particular video, I am going to be talking about three main aspects of pharma that we have not covered so far. So one is yes, core general pharma. We shall also be including antimicrobials here, and then we'll be talking about anti-cancer drugs with monoclonal antibodies. There is a recent update about immune checkpoint inhibitors, but that I'll be discussing in pathology in general path, where I've covered immuno so that it's integrated well. Rest of it we've already covered in different sections, the most important of which is psyche pharmacology that we've done in psychiatry. Apart from that, all of the others have been in the respective systems. So I hope you are first doing the systems and then coming to these general videos, alright? So just keep that in mind so that it's easier for you to comprehend and bring everything together. Okay, so then let's begin with general pharma. A lot of images, graph based questions and a few numerical based questions can also come from here. So I've tried to cover that in the very beginning so that you are confident, especially for students who are appearing for NEET and INICET. This is more important. Okay, so here you get a graph about concentration and time, and they ask you what would be the area under the curve. So area under the curve is what represents F. F means bioavailability. So bioavailability is basically described by the area under the curve. That is very, very important. Okay, that the bioavailability for IV injected drugs is always gonna be 100%, right? So it's gonna be 100%, whereas for oral it's gonna range from somewhere around 5 to 100%. So it's gonna be much lesser. So this is a formula to calculate the bioavailability. So basically it is up the area under the curve of oral upon the dose of oral upon area under the curve of IV upon the dose of IV. So this is how it becomes. No need to remember this formula per se. They only end up asking how do you calculate the F. So that is the area under the curve. Now when we talk about this graph here, very, very important. So this is the fraction of the maximal biological response. So what is the biological response with the dose? So this is your dose response curve or a quantal dose response curve, and what you need to know is how is the potency and efficacy related. Again, something which is asked very frequently. So remember, you can remember a mnemonic HELP here. Okay, so efficacy basically will be determined by the height, whereas right and left will tell you about the potency. So higher is the height, higher is the efficacy. So out of drug X, Y and Z, we can say that X and Y have equal efficacy, which is higher than Z. So height relates to the efficacy. Potency is the right left. So whatever is on the most left side is going to be the most potent, and as you see, the higher dose is required for a similar response. The potency keeps reducing. So X is more potent than Y than Z. So that's how we can know about the potency. Efficacy, I can say X equals Y more than Z in this case. Okay, so I hope you understand this concept. Now they also ask you about this, that how do you define all of these names. Okay, so this is the pure agonist, which is giving you the maximum effect. This here is a partial agonist, which is giving you a effect which is not as much as the agonist, but it is still positive. This here is the antagonist, which is showing no effect, whereas this is the inverse agonist. The only thing you're gonna confuse here is antagonist and inverse agonist. Other two are very self-explanatory. Okay, so this is what you want to remember. So just to give you few more terms about the drug combinations, if you use two drugs and both of their sum is added, this is what is known very self-explanatory as an additive effect. So this is an additive effect where aspirin and PCM, both of them are going to bring their effect, and it's going to be a sum of both of their effect. They're not doing anything else. Both of them are doing their own thing. So it's an additive effect. If two drugs combine and they lead to a higher effect, means one drug potentiates the action of the other and the result is more, so 2 plus 2 more than 4 helps you understand that this is a synergistic response. So this is what is known as synergistic, where clopidogrel plus aspirin forms a very good combination. On the other hand, if I have carbidopa-levodopa combination, what that does is carbidopa is actually increasing the effect of levodopa by inhibiting its metabolism, but overall it does not have its own effect. If I just give carbidopa, it's not gonna work, but it does increase the effect of levodopa overall when combined with it. Alright, so such an effect is called as a potentiator. Okay, so these are the three terms that you want to keep in mind. Additive is addition, synergistic is more. All right, there's so much synergy. We need synergy so that we can bring everybody up, whereas potentiator itself does not have any action, but it increases the effect of somebody else. So that's a potentiator. When we talk about tachyphylaxis, what does tachyphylaxis mean? So you want to remember the buzzword here, repeated dosage. When you give something repeatedly, the effect reduces. All right, so the overall effect reduces. That is known as tachyphylaxis. What is a permissive effect? A permissive effect is like some substance is needed for another to act. Like cortisol acts as a permissive effect for catecholamines. Only when cortisol is present can catecholamines act. All right, so that is known as permissive effect. So these are a few terms which I thought would be confusing and could be tested, so that is important. Now let's talk about all of the opioid agonist, partial agonist, and antagonist. This is again something very, very frequently tested. Here the first category that I want to go to is the third one, because this has the highest potential of getting asked. So what are your mixed agonist antagonists? So you have nalbuphine, pentazocine, and butarphenol. So this is like core choti copy, just like keep these three drugs together, three NBP drugs together, because this is what is usually tested. So what you want to remember is buprenorphine is not mixed. This is usually the fourth option because students confuse butorphanol from buprenorphine. All right, so you want to remember that just like nalbuphine, how LB and P are here and LB and P are here, in buprenorphine you don't have. So you need a BPL to be mixed. Okay, so this is how we can remember. I've just discovered this while teaching. So you want to remember BPL is needed to be a mixed agonist antagonist. Fine. Other that you must be knowing, so full agonist is morphine, heroin, meperidine, methadone, codeine, which is frequently seen in cough syrups, and fentanyl. Okay, whereas antagonist also, we've done this in psychiatry. Naloxone is the antagonist that we give anytime there's toxicity, whereas for long term we are gonna give naltrexone, right? So these are your antagonists. So this is the category which I want you to pay attention to. So this is done. Now the last two graphs that we learned, about the potency, efficacy, and about the agonist, antagonist. Now we bring it all together. So anytime we have this relation where agonist and then another drug together reduces the potency, what is this? Is this a competitive antagonist, non-competitive, or a partial agonist? This would be the options. So anytime the potency is reduced, remember compotency is how you can remember. So competitive antagonists are gonna reduce the potency and they have no change on the efficacy. All right, so this is what happens when you have competitive inhibitor or competitive antagonists. On the other hand, if you have a non-competitive antagonist, you're gonna have efficacy which drops. So you can see how potency does not change but the efficacy changes. So this is a very, very potential question. Okay, so this is non-competitive. On the other hand, what does a partial agonist do? A partial agonist will reduce the efficacy again and it would have its own potency. Potency is independent of the original drug. All right, it can decrease, it can increase, it can do whatever, but the efficacy reduces. So the question would be, if efficacy is not changing, the only thing it can be is competitive antagonist, right? So that's how you remember this. Going on to a few formulae which could be asked, and you could get a few numericals which have also been tested in the past. So first of all, what is the volume of distribution? Again, as I keep saying, no need to memorize. Anytime they're testing the volume, it has to be the amount upon concentration, right? So it has to be mg upon mg per dl, so that dl comes into the unit, right? It comes into the numerator. So this is how you know, there's no need to memorize. So what is the amount of drug you've injected upon the concentration? If you remember, this is exactly how we calculated the body fluid volumes in physiology. Yes, so this is volume of distribution, exactly same formula. What is the half-life? This is important. So this is 0.7 or 0.693 into volume of distribution upon clearance. So a lot of times VD by CL is known as a constant constant, so they can give you this value also. So you just got to do a 0.7 into that constant. Okay, so this is volume of distribution upon clearance, and just like how it's sitting, volume of distribution is on the top and clearance is in the denominator. So you can remember this, all right. So clearance is how much is the rate of elimination of drug upon the plasma concentration. So this also we have already done in renal physio. This is just like UV by P. So what is the urine concentration into the volume or the rate of clearance and plasma concentration. So this is how you're gonna get a unit of ml per minute. So U and T concentrations cancel out. So V is ml per minute. All right. So again, just to confirm, again, even if you forget T half, what was the formula? Volume is ml and clearance is ml per minute. So that is how you end up with minute in the T half. You're getting my point? So no need to remember formulae. Look at the question, figure out, what should be where. Okay? Now we go on to loading dose and maintenance dose. So whenever you're starting to load anything, whenever you're starting to give a drug, you want it to reach the entire body wherever it has to and then reach a steady state. So we take into account volume of distribution here. It is basically where all the drug wants to go, I need to give in loading dose. So this is the concentration into the distribution volume. On the other hand, once that is done, once all the sites are saturated, now I just have to account for clearance. So for maintenance, we are only looking at what is going out of the body. I just need to supplement that. So that's how you remember that for loading it's volume, but for maintenance, whatever is going out, I just give that. So that's clearance. Okay, so this is how we are gonna be remembering all of this stuff. Then we have this therapeutic index concept. What is the difference between the dose where it is fully efficacious and when it starts to get toxic? So for this we have the ED50 and we have the TD50, which is the median efficacy dose and median toxic dose. So the therapeutic index is basically the ratio of the TD50 upon the ED50. In case of animal studies, it would be lethal dose. So it's the same thing. TD or LD basically means the same thing. So if they tell you that the toxicity dose say is 500 mg, whereas the efficacy dose is 100 mg, so the therapeutic index becomes 5, right? The therapeutic index becomes 5. So this is how you could get questions. What you also want to remember here is that drugs with narrow therapeutic index, like we've done MgSO4, we've done lithium, theophylline, all of these have a narrow therapeutic index. So this is about this. Now we talk about CYP metabolism. All right, so CYP metabolism, we have inducers and we have inhibitors. So there are a lot of mnemonics which are there, but I just want to highlight the important points that are very frequently tested. So remember, all anti-epileptics are inducers except one, which is valproate. So valproate is an inhibitor. So that's what we remember. We don't care about others. Everybody else is inducer, right? Whether it's phenobarb, whatever they give you, remember valproate is inhibitor. All ATT are inducers except INH. So I only care for INH, that INH is an inhibitor and the name only tells me INH inhibitor. Yes, so valproate, isoniazide inhibitors. Yeah, that's my takeaway from here. Then out of all the antibiotics, again a lot of antibiotics are inhibitors like fluoroquinolone or ciprofloxacin, macrolides particularly erythromycin and chloramphenicol, and out of antifungals we have azoles. So all of these are inhibitors. So now the exception being, which is the antibiotic which is an inducer, so that is griseofulvin, and we have protease inhibitors. So remember, griseofulvin and nevirapine, these are two antimicrobials which are inducers. Okay, so this is what we are remembering. Apart from that, you can also see protease inhibitor ritonavir here. So ritonavir, protease inhibitor, a lot of times we are giving this as booster. We want to increase the half-life, so we are giving enzyme inhibitors so that we can increase the life of that drug. All right, so that is known as ritonavir boosting. So this is about the antimicrobials. Apart from that, we have smoking and ethanol, which are your inducers. Okay, so chronic ethanol is an inducer. Acute ethanol, a lot of places say, is an inhibitor. Okay, so basically what is the end point? All anti-epileptics, all ATT. Two exceptions, valproate and INH, griseofulvin and nevirapine, and smoking and ethanol. These are inducers. Anything else is going to be an inhibitor. Yeah. So we've done all antimicrobials. We know INH, valproate. We know 3 antiarrhythmic drugs. So amiodarone, verapamil and diltiazem. We have omeprazole, which is very important, and we have cimetidine. So this I've also told you in the GI system. And grape juice. So if you drink alcohol, you're going to be induced, but if you drink grape juice, you're going to be inhibited. It's going to have no effect. Okay, so grape juice is inhibitor. Fine. Then let's do the substrates. So substrates of a few CYP enzymes which are important. So we have 3A4. So for this, we have two drugs which are anti-metabolites which always go together. So cyclosporin, tacrolimus. Then we have statins, we have amiodarone, we have ritonavir. Out of this, can you see how amiodarone, ritonavir belong together in inhibitors? Yes. And then we have the CAT drugs. These CAT drugs have been withdrawn from the market because they do QT prolongation. So these are not relevant as such, but these are 3A4 substrates. CYP2D6 substrates. So we have beta blockers, we have SSRIs, and we have antiarrhythmics except amiodarone, because amiodarone we have already seen. The most important ones which have been asked recently is CYP2C19, that is clopidogrel, and CYP2C9, that is warfarin and phenytoin. So this is like pure choti copy stuff that you have to just revisit. Okay, so here you also want to remember the interaction between omeprazole and clopidogrel, which is very frequently tested. Okay, so now we go on to kinetics. So we have first order, we have zero order kinetics. They can give you this graph and they can ask you, please tell which is which. So now we go into kinetics of the different drugs. So we can have zero order or we can have first order kinetics. So anytime you see that the plasma concentration is going down linearly, this is a zero order kinetics. Whereas if you see there is a logarithmic or an exponential decrease, this is known as first order kinetics. So in zero order kinetics, the point is that the amount of drug which is cleared per unit time remains constant, whereas here in first order, first say first and first say fraction of the drug which has been cleared remains constant. Alright, so this is what is very, very important. So here in first order kinetics, remember the T half, the clearance is all gonna be constant. Okay, so what they say is that after around 4-5 cycles, after around 4-5 T halves, the steady state for first order kinetics is reached. So 4-5 T halves is usually needed for the steady state to be needed for first order kinetics. Alright, so this is about the identification of graphs that can be tested. Then you also want to know about the metabolism. So there is phase 1 metabolism and there is phase 2. Predominantly lipophilic drugs are gonna undergo phase 1. So here you have your simple metabolism like reduction, oxidation, hydrolysis. Polar drugs or water soluble drugs predominantly undergo phase 2, and here you have reactions like methylation, glucuronidation, acetylation, sulfation. So a big compound is being added. So this is a recent NEET question, very simple. If you are adding some heavy duty stuff, it's phase 2. Okay, so this makes them hydrophilic and that is how they can be excreted. Acetylation per se is important not for excretion but for activation of a lot of drugs, and we remember the SHIP drugs. So your sulfa drugs, hydralazine, isoniazide and procainamide. And SHIP drugs also help us remember what? That they can cause lupus. They can cause drug induced lupus. Okay, so this is about the enzyme kinetics. Now I have a few things that I want to show you particularly for INICET exams. So this is about the changes that norepinephrine, epinephrine and isoproterenol have on different receptors. Okay, so remember this is the concept here that norepinephrine has more alpha action than beta action. So what does it do to the blood pressure? So what it's gonna do predominantly is increase the blood pressure. You can see how this is, the first line is systolic blood pressure, this is diastolic blood pressure, and this is the mean arterial pressure. Yeah, mean arterial pressure is always 2/3 towards diastolic and 1/3 towards systolic. So that's why it is slightly lower. So you can see how it's widening the pulse pressure. So norepinephrine predominantly acts on alpha receptor, causes vasoconstriction, and that is why the BP is increasing. Because beta reaction is lesser, it does not cause a lot of tachycardia and there is reflex brady. Very important. What happens when you give any? Predominantly BP increases but heart rate goes down. When you give epinephrine, what you want to remember, this is not entirely true. What you want to remember is alpha 1 and beta 2 action. Both of them are there. So alpha 1 action causes vasoconstriction, whereas this produces vasodilation. Now, when the dosage is complete, when the dosage is optimal, it's going to be this which predominates. It's going to be the alpha 1 action. But at lower doses, it's going to be the vasodilation which is going to predominate. Okay. So overall, we are going to have an increase in the blood pressure. Alright. So it is going to be an increase in the blood pressure with epinephrine. But because there is beta action as well, you're going to have tachycardia. So with epinephrine, the BP increases and the heart rate increases. Okay, so that is what you need to understand. Whereas isoproterenol is only going to have beta action. So what you're going to have is heart rate increases, but the blood pressure falls. Okay, so this is what you need to learn about these three agents. Now let's learn about this phenomenon, that is vasomotor reversal of Dale. So what happens here? Anytime we give adrenaline, you are seeing how the BP first falls. As the level keeps going down, now you're gonna have, so here you had alpha 1 predominating, vasoconstriction happening. As the levels go down in the serum, you're gonna have BP falling, because now you have the beta receptor which is predominant. So this is vasodilating, right? So this is what is the normal response. When you give an alpha blocker, what you're going to see is, after giving alpha blocker, if there is adrenaline, because this is ablated, this is gone, you're going to have this vasodilation, you're going to have a fall in blood pressure. So this fall in blood pressure after giving an alpha blocker is what is known as vasomotor reversal of Dale, and this is what is very important in pheochromocytoma. So if you have a pheochromocytoma which is producing adrenaline, you can't just give alpha blocker alone. You need to give both alpha blocker plus beta blocker before taking the patient up for surgery, otherwise patient is going to have hypotension. So this is a simplified version of this that can be tested. Now going on to antimicrobials, so very scary looking slide here. What you want to do is mechanism. So we are going to be talking about the main mechanisms of different antimicrobials. We start off with the largest category, which is the cell wall synthesis inhibitors. So now in bacteria, what we have is a peptidoglycan cell wall. Okay, so you can have the glycan not forming, you can have the peptide not forming, or the cross linking is not happening. So these are the various categories. So for glycan, we need something known as muramic acid. If I block the synthesis of this, the drug that does this is phosphomycin. It's a drug that we use for second line as second line drug for UTI. If you do not allow the pentapeptide, that is the D-ALA chain to form, that is cycloserine. It is again a second line ATT drug. Okay. If you do not allow the bactoprenol transporter to take out the peptidoglycan, you will have bacitracin. So B from B, bacitracin is how you can remember. Bacitracin is something that is used as a topical agent for MRSA. So for MRSA, we can give it as a topical agent. Now, we have transglycosylase and we have transpeptidase. So transglycosylase is inhibited by vancomycin. You know how vans, are very long. So van is very long. So that's how you remember glycosylase is responsible for elongation. It is responsible for the elongation of peptidoglycan chain that is blocked by vancomycin. On the other hand, beta-lactams inhibit transpeptidase, which is responsible for cross-linking. Okay, so this is the mechanism that is different here. I hope this is clear. Now, we go into the different beta-lactams here. So we are going into the different beta-lactams category. We have done the mechanism. So the OG beta-lactam was penicillin G, OG. It had a lot of problems. It was only effective in the parenteral route. It had a very narrow spectrum, and it was very sensitive to beta lactamases. So we needed to find a way out of it. So first thing we could do was create a wide spectrum penicillin. So we had ampicillin, amoxicillin. We had other beta lactams that we found for extended spectrum. So this was sorted. Then we had to find penicillinase resistant penicillins. So those are the condom drugs. So this is how you can remember: cloxacillin, oxacillin. Yeah. Then nafcillin, dicloxacillin, Oxacillin we've already done, and then M for methicillin. So methicillin, I'm sure you know MRSA. So these are all penicillinase resistant penicillins. Within the wide spectrum, we also have piperacillin that was found. In addition, we also have beta-lactamase inhibitors. So we could combine these beta-lactams with beta-lactamase inhibitors, the classic example being amoxiclav. So you combine amoxicillin with clavulanic acid, which is a beta-lactamase inhibitor. Alright, or you could combine piperacillin with tazobactam. Alright, so this is how you can remember them. Then we have cephalosporins, which are 5 generations. So in every first generation, you're gonna find the letter FA. You know how first aid is. In fact, there's a chart from first aid. So FA is first aid, and that's a very good book. That should be a first resource. Yeah. So cefazolin. Then you remember Fox 4. Wherever you have Cefox, C4, that is your second generation. Ceftriaxone and cefixetine are your third generation. So these are the odd one outs. Anytime you have PIME coming in, pi, so value of pi is 3.4, so you want to remember almost 4. So this is cefepime, and ceftarolin, wherever you have roll, yes, ceftabiprole, ceftarolin, rolling on the floor laughing. So you want to remember Florsafe, 5th generation, and this is the only category effective against MRSA. Okay, so this is your cephalosporin generation. Then we have carbapenems, in which we have imipenem. So carbapenems are your extended spectrum. They have a very wide spectrum at which they act. The first one was imipenem. So remember, imipenem was given with cilastatin. Why? Because this would inhibit the dihydropeptidase enzyme that metabolizes imipenem, and also a side effect was seizures. So with imipenem, you remember 2 SIRS, cilastatin and seizures. And then monobactam or aztreonam. So mono acts alone because this is the only category which does not have any cross allergy. All of the other beta lactams have cross allergy, meaning if you are allergic to penicillin, you will be allergic to cephalosporins also, carbapenems also, but not monobactams like that. Okay, so this is about that. And now glycopeptides, we have vancomycin, like we already discussed, which blocks the elongation. Yeah, so that is transglycosylase. Also want to remember something known as red man syndrome. So what vancomycin does is it induces the release of histamine, and that results in this flushing. Contrast this with niacin that I have taught you in CVS, which induces prostaglandin release, and that's why there's flushing. So that can be blocked with NSAIDs, right? So this is what we want to remember here. Then you have a few drugs which inhibit membrane integrity. So these are daptomycins for gram positive and polymyxins for gram negative. So this large chunk is done. All of the uses, I'm going to compile them all and we're going to do them together. So we're not doing them right now. Now we go to the other mechanism, that is protein synthesis inhibitors. So here you need to know what are 30S inhibitors, what are 50S inhibitors. So remember, buy at 30, sell at 50. You want to make profit, so you buy at 30, you sell at 50. So aminoglycosides and tetracyclines are your 30S subunit inhibitors. Aminoglycosides, remember, they cause misreading, alright, and they require oxygen to act, and that is why they are not effective against anaerobes. Okay, so this is very important, multiple times asked. Aminoglycosides, so you have gentamicin, neomycin, amikacin, tobramycin, streptomycin. We use this for TB as second line. Neomycin is also used in hepatic encephalopathy for clearance of the gut microflora. Tigecycline, tetracycline, remember tigecycline does not have efficacy against Pseudomonas. It is not effective against Pseudomonas is what you want to remember. Then what is the mechanism? So T for tetracycline, T for tRNA. They cause inhibition of the tRNA. So this is about buy at 30, sells at 50. So you have streptogranins, you have cercloramphenicol, cerclindamycin, cells, erythromycin and linezolide. So what chloramphenicol, remember phenicol like fevicol, so this inhibits the peptidyl transferase. This inhibits peptidyl transferase. Then you have clindamycin, which is a drug that is effective against anaerobes above the diaphragm. Linezolide, very important. So this is effective against warsa. Apart from that, you want to remember something very important. This can cause neuropathy and this can cause serotonin syndrome. So linezolide can cause serotonin syndrome. As far as macrolides are concerned, they are a drug of choice for a lot of conditions which we shall discuss. But what we have done is these are CYP inhibitors, and you also want to remember these are prokinetics. I have told you this in GI physio. They bind to the motilin receptors, yeah, and erythromycin is contraindicated in pregnancy because it is implicated with CHPS, congenital hypertrophic pyloric stenosis, whereas other macrolides are safe in pregnancy. And finally, we have quinpristine, dalfapristine, which is also effective against warsa. Okay, so this is how we are remembering bi at 30, cells at 50. Then we go into the next category of antimetabolites. So what you're seeing here are the antimetabolites. So here let's have a look. So we have dihydropteroate synthase, which block the synthesis of dihydropteric acid. So this is your sulfonamides and dapsone. Then you have dihydrofolate reductase inhibitors, which is trimethoprim and pyrimethamine. Now independently these are static drugs, but when you combine them it becomes SIDL. So these are frequently used as a combination, that is TMP SMX. So trimethoprim and sulfamethoxazole is used together in a concentration of 1:5. So this is your drug combination. If you look at the plasma, this becomes 1:20. Alright, so this is what you want to remember about these drugs. Then very important for the exams are the gyrase inhibitors, so fluoroquinolones. So here they keep asking you the same question again and again. PMT, which are the fluoroquinolones that are safe in renal failure? So you have pafloxacin, you have moxifloxacin, and you have trovafloxacin. So these are your PMT drugs which are safe in renal failure. Then you also want to remember these are CYP inhibitors. So just like macrolides, these are also CYP inhibitors and they prolong QT. Very important. Again, just like macrolides, these are also QT prolongers. So two areas where they belong together. And the most important thing you can't forget is that they cause tendon rupture. This is so frequently tested. Which drugs cause tendon rupture? This is fluoroquinolones, and that is why these are contraindicated in children. Okay. Then we have a drug which breaks the DNA via free radicals. So where is metrogyl used? So you want to remember GetGap. Alright, so you can remember GetGap, a very catchy mnemonic. So this is the drug of choice for Giardia. This is the drug of choice for Entamoeba, Trichomonas, Gardnerella, anaerobes below the diaphragm, and we can also use it in H. pylori. So these are the indications I've covered here. I'm not going to repeat these. Alright, so GetGap we have sorted, others now we are going to be seeing. So this is a holistic mechanism of antimicrobials. If you do this, half of your antimicrobials is sorted. The other half, let's sort it now. So now we are going to be writing down what are the different conditions where different drugs come into play, and I've written this in the order in which we've studied the mechanism so that you remember it stepwise, like how I have taught you. Okay, so actinomyces is OG penicillin. This is one of the very few areas where penicillin is still drug of choice, the other being syphilis. Yeah, so we've already discussed this. Syphilis and actinomyces is where penicillin comes into picture. Then we went into the extended spectrum. So ampicillin is the drug of choice for listeria. This also I've taught you in microbiology. For mastitis, very important, we have cloxacillin. So now we are going into the condom category. One by one we are going down. Yes, that is what we are doing. So this is cloxacillin. Mastitis frequently is because of the staph aureus from the baby's mouth. That's also a repeat question, and you do not stop breastfeeding in mastitis. Two related questions. Coming to surgical site infection, we are going into cephalosporins. So first generation cephalosporins are frequently given. So we use cefazolin. So cefazolin is what is used for surgical site infection, and we give it half an hour to 1 hour before the incision. Okay, so that is the usual time at which this is given, so that during incision the levels are highest. As far as anaerobes are concerned, remember above the diaphragm the drug of choice is clindamycin, whereas below the diaphragm the drug of choice is metronidazole, metrogyl. Okay, so this is anaerobes. Very important for Neisseria, for Lyme's disease, enteric fever, we have third generation, so you can give cefixime or ceftriaxone. Okay, so Neisseria, Lyme's disease, enteric fever. Pseudomonas, it is ceftazidime. Very, very important. Ceftazidime is the drug of choice. So third generation cephalosporins are effective. Then we remember the very, very efficacious drugs. So these are very bad bacteria. Enterobacter, Acinetobacter. In fact, Acinetobacter is now becoming the most common cause for ventilator associated pneumonia. So we are gonna need carbapenems, right? So we have carbapenems coming here. Remember, SIRSA I told you, cilastatin and seizures. Plague and tularemia, we have streptomycin which comes in, and rickettsia cholera, we have tetracycline. So these are our ancient drugs for ancient diseases. Then the latest, the new diseases, the new drug. Everywhere you're going to have this. So atypical pneumonia because of mycoplasma, legionella, mycoplasma, chlamydia, pertussis, diphtheria. All of this we have macrolides. Okay, so macrolides are the drug of choice for all of these. Pneumocystis burkholderia and nocardia. Do you remember this? SNAP? Yes. So penicillin is actinomycin, whereas nocardia is TMP SMX. So this is cotrimoxazole. Alright. So this is cotrimoxazole. Then finally, meningococcal anthrax, UTI, traveler's diarrhea, the only thing remaining, fluoroquinolones, gyrase inhibitors, tendon rupture, CYP inhibitors, Q2 prolongation. Alright, so this is about all of the antimicrobials. Talking about anti-helminthian drugs right here, the only thing you want to know is the drug of choice. Remember, for cystoles and trematodes, it is praziquantel. For liver fluke, it is triclabendazole. For nematodes and hydatid, it is albendazole. For filariasis, I am sure you know, it is DEC. Onchocerca strongyloides is ivermectin. Kala-azar liposomal amphotericin B is the drug of choice. Apart from that, miltefosine can also be given. For cryptosporidium, it is nitazoxanide. Whereas cyclospora and isospora is again TMP SMX. So TMP SMX seems like a very important category, isn't it? So this can be tested. This is also a repeat question. Alright, so this is a compilation of all of the antimicrobials. Let's do further questions from this. Alright, so I've just basically brought it all together, and then I'm just giving you the questions which can be asked from antimicrobials. Otherwise, if you just go on to do proper antimicrobials, it is like 5-6 hours straight. Okay, so I've just told you what could be asked and handpicked a few things here and there. So instead of telling you which is the drug of choice, now I'm gonna tell you which drug is not effective, and this is gonna help you a lot. Okay, so for mycoplasma, remember, cell wall inhibitors, like the first category that we did, is not effective. What is the drug of choice? Let's just do that simultaneously. It is macrolides, as we discussed. For pseudomonas, remember, vancomycin is not effective. You might feel vancomycin is effective against MRSA, must be against pseudomonas. No, and that is why I am giving you this table. So these are the ones which are not effective. For pseudomonas, the drug of choice is ceftazidime. Anaerobes, as we discussed, aminoglycosides need oxygen to act, so they're not effective, and we have Clinda and metronidazole to be drug of choice. For MRSA, remember, beta-lactams are not effective except 5th generation. So this is the exception wherein you have ceftabiprole, which is effective against MRSA. Let's just talk about Versa right here. So for Versa, remember, daptomycin is the drug of choice, but because daptomycin is degraded by the surfactant, it cannot act in the lungs. So Versa pneumonia, Versa in the lungs, L for lungs, L for linezolid becomes the drug of choice. Apart from that, ciftarolin and quinpristine, dalfopristine are also effective. So these are drugs which are effective against Versa. Salmonella, remember, aminoglycosides is not effective. The drug of choice would be 3rd generation cephalosporins. Okay, so this is about the important bacteria. MRSA, the drug of choice is vancomycin, like we discussed. Okay, 3 categories which is safe. So PCM, yeah, paracetamol is also safe in pregnancy. So penicillin group is safe, clindamycin is safe, and macrolides except erythromycin are safe. Not erythromycin because it has a risk of CHPS. Okay. Now, how do different drugs get resistance? Again, very important. So, beta lactams, you know beta lactamases. So, beta lactams develop resistance via enzyme. In addition, you have two more categories which have developed resistance because of an enzyme. So, here you have aminoglycosides and chloramphenicol. Remember Fevicol, peptidyl transferase. So, these are the three categories which are developing resistance with the help of enzyme. Very important question, altered target. So, here you want to remember MRSA. What happens in MRSA? The penicillin binding protein is changed to PB2A. Instead of PBP, it changes its morphology to PBP2A, and that is how it develops resistance. VRSA is also altered target. So, instead of D-alanine, it becomes D-lactate, and that is how it develops resistance. In addition, you have two more categories. So, you have linezolide and you have macrolides, which also have altered targets. So, just remember this category, very important. MRSA, VRSA, linezolide, macrolides. Efflux pump, again very unique, very important, is tetracyclines. Okay, so this you should remember. Fine. So, everything else becomes enzyme mediated. So, this is about antimicrobials. Finishing off antimicrobials, now we will be going into antifungals, antitubercular and antiviral. So, one slide on each of these, okay. So, antifungals, you need to know the mechanisms. So, first of all, we have the polleins, which include amphotericin B and nystatin. So, here you want to remember amphotericin B. It causes a pore in the cell membrane, alright. So, that is why it acts synergistically with flucytosine, which is a nucleic acid inhibitor. So, it creates a pore through which more of flucytosine can go and block the cell, and that's why these are two synergistic drugs, like we said. Alright, so this is about these two drugs. There are two categories which are CIDL drugs. So, we have cell membrane integrity inhibitors, and then you have lanosterol synthesis inhibitor, that is terbinafine, which is also a CIDL drug. Everybody else is static, okay. So, not very important, but you can remember that. We have cell wall synthesis inhibitors. So, these are gonna bind to caspofungins, and these are your candins, okay. So, you can remember all C's here, and this is given for systemic candidiasis as well. So, these are your candin drugs, and then you have your ergosterol synthesis inhibitors, that is your demethylase inhibitors, which are azole. So, remember squalene epoxidase is terbinafine, 14 alpha demethylase is azole. So, here you have all of the azoles. I will tell you each of these as one-liners. Which is the drug of choice for any severe systemic fungal infection or mucormycosis? We have to go for amphotericin B. Why it's saved for the worst infections? Because it has so many side effects. It has an infusion reaction, nephrotoxic, RTA type 1. So, 1 and A1 going together, hypokalemia, and it's also bone marrow suppressant. So, all of these deadly effects with AMP-B. So, we save it for mucor or severe infection. For Candida and Cryptococcus, remember the drug of choice is fluconazole. Alright, so fluconazole is the drug of choice for both C's, and it also happens to have the maximum oral and CNS bioavailability. That's why for Crypto, it is the maintenance agent of choice. For Aspergillus, we have already seen it is gonna be voriconazole. So, for Aspergillus, it is voriconazole, and from V only you wanna remember it produces visual changes. Alright, so V for visual, V for voriconazole. Then for the endemic mycosis, Histoplasma, Sporotrix, blastomyces, we have itraconazole, right? So, we have itraconazole coming in here. The azole, which is useful in mucor. So, mucor so far only AMP-B was effective, but now we have isavu and we have posaconazole, which are effective against mucormycosis. And also a repeat question, the azole with antipruritic or anti-inflammatory action is sertraconazole. Okay, so this is about all of the one-liners that you wanna remember. Now going on to ATT. So again, antitubercular drugs mechanism. So first we start off with isoniazid, INH. It's gonna inhibit mycolic acid synthesis. So how you get resistance against isoniazid is important. It's via the CAT-G gene. Okay. Then the name itself is gonna tell you everything. INH. Do you remember? This is a CYP inhibitor. It injures neurons and hepatocytes. injures neurons and hepatocytes. So this is neurotoxic and it is hepatotoxic. Alright, so this is what you want to remember, that it is injuring neurons and hepatocytes. So this is, so it causes peripheral neuropathy, it causes hepatotoxicity. So this is what we want to remember about INH. Very, very important. We have already studied this in biochemistry. This blocks the pyridoxine and that is why it can also cause sideroblastic anemia, acquired niacin deficiency as well, right? So this is isoniazide. Then we have ethambutol. Again, ethambutol inhibits the cell wall synthesis by inhibiting this enzyme here. So ethambutol, from today you are gonna call this ithambutol, which means it has optic neuritis, right? So it causes optic neuritis. It can cause distorted color perception and that is why this is contraindicated in children less than 6 years. So this is ithambutol. Then we have pyrazinamide, drug Z. So Z, remember, is the only drug which is gonna be having intracellular action. So it has an intracellular action, meaning it kills the mycobacterium within the cells. So it has a sterilizing action. That is what is known as a sterilizing action. But it has very bad effects. It causes hyperuricemia. It also causes hepatotoxicity. So it's a hepatotoxic drug with hyperuricemia. So this is pyrazinamide. Then you have rifampicin, which blocks the RNA synthesis. So it blocks the DNA dependent RNA synthase. So we have rifampin, and along with rifampin we have rifabutin. So you want to remember, rifabutin is what is preferred in HIV AIDS patients because it does not cause enzyme induction. Rifampicin, if you remember, is an inducer, right? So that will increase the metabolism of the HIV drug. So in HIV we are preferring to use rifabutin. Okay, so this is about all of the ATT drugs. We also know the injectable streptomycin. This is contraindicated in pregnancy, and you should remember all aminoglycosides have a side effect none. So these are all nephrotoxic, these are all ototoxic, and they also cause neuromuscular blockade. So remember, non-side effects for not just streptomycin but all aminoglycosides. Okay, now definitions. So MDR-TB, remember, we have resistance to INH plus rifampicin. XDR is when you have MDR, so H plus R plus you have a resistance to fluoroquinolone and a second line injectable. So this is the updated definition, where you have resistance to kanamycin, amikacin or caprimycin as well. So in these patients the regimen is this follows. So what you want to remember is the order LCZE. Alright, so LEC-Z. Let's remember LEC-Z. This is going to be common to both of the regimens, intensive and continuation. So the phase would last from 9 to 11 months. Okay, so LEC-Z is common to both of them. So levofloxacin, clofazimine, pyrazinamide and ethambutol are common to both of them. In addition, there are 3 drugs in the initiation phase. So you have bedaquiline, which is given to all patients for 6 months. This is an ATP synthase inhibitor, very important. High dose of isoniazide, even though it is resistant, we give a high dose. And ethionamide, not ethambutol. Ethionamide is hepatotoxic. Don't confuse this with ethambutol. Ethambutol is ithambutol. Ethionamide is hepatotoxic. Okay, so you just remember LEC-Z and you remember BHE, which is added in the initiation phase. So this takes care of ATT for us. Finally, going into antiviral. So here most of the questions are going to come from the mechanism. Now we go on to antiviral drugs, which the main is going to be the mechanism of action. Alright, so here the first thing is entry inhibitors, and these are all recent drugs, so you do expect questions from the mechanisms here. So we have fostemsavir, which is a GP120 inhibitor, and you have enfoviritide, which is 41 inhibitor. 2 new drugs, CC4 inhibitor is ibalizumab and CCR5 is maraviroc. So the first and the last one are oral drugs, and that is also something that can be tested. So this is again our core choti copy stuff, okay, that we need to remember. Fine. After the HIV virus has entered, now you have reverse transcriptase which come into play. So you can have NRTIs or you can have NNRTIs. In NRTIs, we have all of these drugs, whereas NNRTIs, the list to remember, you have efavirenz and nevirapine. Newer drugs again, integrase, so you look out for GR here. So these are your gravids. So these gravid drugs are integrase inhibitors. Okay, so this is gravir inhibitor. So we give cobicistat with these drugs in order to increase their half-lives and to decrease the metabolism. Protease inhibitors are used very frequently. So these are all of your atazanavir, darunavir, and these are basically drugs which we give with ritonavir, which is known as ritonavir boosting. As we saw, ritonavir is an enzyme inhibitor, and that is, it is going to increase the half-lives of these drugs. Okay, so this is about the drug classification. Now let's compile the side effects and then I'll tell you the regimens. Okay, so maximum neuropathy, remember, is with stavudine. So stavudine causes the maximum neuropathy. This is an NRTI. Maximum pancreatitis is caused by didanosine. So didanosine, again an NRTI, causes maximum pancreatitis. Bone marrow suppression and liver toxicity, both of these are maximum with zidovudine. Alright, so zidovudine is the maximum for two very important effects, BM and hepatotoxicity. And if you remember pyrazinamide Z, so Z always has a lot of toxicity, right? So you want to remember zidovudine, BM suppression, hepatotoxic. Nephrotoxic, N for tenofovir. MI is associated with abacavir, and the safest is lamivudine. Okay, so the safest drug here is lamivudine, and that is why you will see that it figures in all regimens. No matter what, it always figures. Okay. Then, as far as NNRTIs are concerned, the best to prevent vertical transmission is going to be nevirapine, whereas teratogenic and vivid dreams are associated with efavirenz. So, VI, vivid is how you can remember. Then protease inhibitors are associated with a lot of dystrophy, lipodystrophy. Just like we saw with insulin, these are also associated with lipodystrophy. The minimum is with atazanavir. So atazanavir has the minimum lipodystrophy, and then stones, I am sure you remember from surgery also, are maximum with indinavir. Alright, so indinavir has the maximum chances of stones, and these are stones which are lucent, and this is very unique that this is the only one which is lucent on CT also. Everybody is lucent on X-ray but opaque on CT. This is the only one which remains lucent on CT as well. Okay, so this is about the side effects. Now for HAART, the newer guidelines say these are the combinations. So you give zidovudine, lamivudine with nevirapine, or you can do tenofovir with lamivudine with efavirenz. Alright, so these are the two combinations that could be given for post-exposure prophylaxis. Very important. You have TLD. So tenofovir, lamivudine and dolutegravir. So this is the updated guidelines. Very important. You want to remember TLD. You know TLD batch, thermoluminescent dosimeter. That's what you want to remember. So the PEP after you have had a needle prick should be started ASAP, but remember within 72 hours. Alright, and this should be given for 4 weeks. So these are two numbers that you want to remember for post exposure prophylaxis. So this takes care of anti-HIV drugs for us. Now going on to anti-cancer drugs. So here again the mechanism is very important, and then we'll look at the side effects. So first of all, we have cell cycle independent drugs. So here one category is the platinum compounds, which is cisplatin. Cisplatin, remember, is going to have three very important side effects: ototoxicity, nephrotoxicity, and it's the most emetogenic drug. So this is cell cycle independent. Then we have the whole category of alkylating agents. In this, what do we have? So first is anthracyclines, which include daunorubicin and doxorubicin. These have a effect of cardiotoxicity. Alright, so these are both cardiotoxic drugs. Busulfan is a alkylating agent. You have actinomycin D, you have nitrogen mustards, nitrosurias and procarbazines. Here you want to remember in nitrogen mustards you have cyclophosphamide and efosfamide. In nitrogen mustards, you want to remember we have efosfamide and cyclophosphamide, which have a very important side effect, that is hemorrhagic cystitis, which is more with efosfamide. The compound that is responsible for this is acrolein. All right, so acrolein is the compound that is responsible for it, and it can be prevented by giving mesna. So mesna can be used to prevent it, and the treatment is with the help of steroids. So these are three things that you want to remember. Now we talk about all of the drugs which can cause pulmonary fibrosis, not plural, pulmonary fibrosis. Remember this. So these are all things which have some sort of vehicle in their name. Okay, so when you have cyclophosphamide, bus, busulfan, bleomycin, blow the horn, carmustine, so car, methotrexate, remember as truck, amiodarone, remember as drawn. Alright, so this is pulmonary fibrosis. These are all of the drugs that you can remember this way. Then we have another list here of drugs which spare bone marrow. All anti-cancer drugs are going to have bone marrow suppression, right, because they're blocking cell division, but these are the bone marrow sparing drugs. So vincristine, Christ, yeah, where Christ comes, bone marrow is spared. Bleomycin and L-asparginase. L-asparginase, remember, has a very important side effect of pancreatitis. So it spares the bone marrow, but it screws the pancreas, alright, so that's what you want to remember. Now, the drugs which are gonna act on the S phase are your antimetabolites. Okay, so antimetabolites are gonna act on the synthesis phase. So here what you have is cladribine, cytarabine. So cladribine is an exception wherein it is cell cycle non-specific, but others are all gonna act on S. So you have cytarabine, you have 5-FU, hydroxyurea, methotrexate, pentostatin, and thiopurines, including 6-mercaptopurine. So what you want to remember here is 6-mercaptopurine, first of all, should not be given with allopurinol. Okay, why do we give allopurinol with anti-cancer drugs? Because they're going to cause hyperuricemia, so we want to prevent gout. But allopurinol is going to stop the efficacy or the activation of 6-MP, and that is why they need not be given together. What pentostatin does is, it is an ADA inhibitor, alright, adenosine deaminase inhibitor. What is methotrexate? As you know, it is dihydrofolate reductase inhibitor, and that is why we give folinic acid along with methotrexate in order to prevent anemia from happening or any other processes of folate from stopping, as we have seen in biochemistry, right? So this is methotrexate. Hydroxyurea, also remember the enzyme, it blocks ribonucleotide reductase. In addition, if you remember, hydroxyurea also increases the hemoglobin F levels, and that is why we were using it in sickle cell anemia, right? So this is about the mechanisms of these three enzymes that you want to remember, and this is how they block the DNA synthesis. G1 and S. So topoisomerase inhibitors are gonna act on both S, G. Alright, so remember a man called SG who is giving topi to everybody. Alright, a cheater called SG is what you can remember. So here you have etoposide and teniposide. Wherever you have two sides, this is topo 2 inhibitor, whereas the TCANs are your topo 1 inhibitors. Alright, so two sides to everything is there, so you want to remember 2 for topo sides. Bleomycin blocks G1 phase and M phase. You want to remember one very important image here, which is flagellate pigmentation. Okay, so it can cause these flagellate pigmentation, that is bleomycin, and we've also seen how bleomycin has two things, right? It is also causing pulmonary fibrosis and it is also bone marrow sparing. Okay, so very, very important, bleomycin. It's also acting on two phases. So G1M, 2 tables it is coming, flagellate pigmentation. So anytime in doubt, you mark bleomycin. Finally, very important, we have done this in general physio as well. Microtubule inhibitors are basically going to block the spindle formation, or they're going to break the spindle. So these are going to act on the M phase. Mitotic phase is where they act. So remember taxanes, how taxanes stabilize a society. You want to remember that taxanes hyperstabilize these microtubules, and that's how they prevent the mitosis from happening, whereas Vinca alkaloids cause increased breakdown of the microtubules. In taxanes, you also want to remember, when you pay too much taxes, you become very sensitive to stuff. Okay, so there is hypersensitivity, which is a very important side effect here. Okay, so this is done. Just two names for HCl and CLL. We have already done this. In HCl, the drug of choice is cladribine, whereas CLL is fludarabine. So these are two important drug of choice that you want to remember. we go on to the side effects. So for this we have the chemo man. So who is the most hematogenic drug? We already remember this is cisplatin. It can have early emesis or early vomiting. The drug of choice remains what is overall the drug of choice for any chemotherapy induced vomiting. So this is your 5-HT3 inhibitor, that is ondansetron. On the other hand, for delayed vomiting we want to give substance P inhibitor, that is aprepitants. Alright, so that is for delayed. Okay, so this is sorted. So now while we are talking about cisplatin, remember it is ototoxic, it is nephrotoxic, and it can also, you can add this, it can also cause emesis. So this is cisplatin for you, oto, nephrotoxic and emetogenic. Then, where do you have peripheral neuropathy? So, you want to remember peripheral neuropathy is by vincristine. Yeah, so Christ spares the bone marrow, but it again causes peripheral neuropathy. So, this is the V of vincristine. Then you can see a C here at the bladder. So, this is cyclophosphamide, which causes hemorrhagic cystitis. So, this causes hemorrhagic cystitis. Okay, so this is cyclophosphamide. Then can you see the B's here? So this is your lung fibrosis, so busulfan, bleomycin, and in addition we know other drugs with all vehicles, so methotrexate is all about the lung fibrosis. Heart, can you see it is D-shaped? So we have doxorubicin and daunorubicin. So anthracyclines are gonna cause cardiotoxicity, and can you see a T in the center? So from surgery, remember trastuzumab. So this is your HER2 new inhibitor, which is also gonna cause cardiotoxicity. And you also want to remember there is a drug which is dexrazoxane, which is gonna prevent the cardiotoxicity. It is a free radical scavenger. Okay, so that is also something that is very, very important. So this is sorted. Also remember one more antidote here. So for nephrotoxicity because of cisplatin, we can give amifostine. Alright, so that's also one good drug that we can remember. So it saves against the nephrotoxicity. Dexrazoxane is a free radical scavenger, helpful against cardiotoxicity. Okay, so this is sorted. Now we go on to the last thing, that is a few monoclonal antibodies. So I'm going to give you a few tricks here which will help you recognize the drugs even if you don't know them. So first of all, just to tell you the origin, anytime they end with U, MAB first of all is monoclonal antibody. So that's going to be there everywhere. When it is U, these are human. If it is ZU, it is humanized. Whereas XI is chimeric, it is a combination of human and animal. Now this is the game changer here. When you know the meaning of these, even if you are not sure about what drug is being asked, you can at least narrow down the category. So if you see that it is palivizumab, VI if you see, it means that it has something to do with viral agent. Cetuximab, so XI, I know it is chimeric. TU, so after basically these, whatever precedes these words is what you look at. So TU means something to do with tumors. So that's how I can guess what it must be doing. Like palivizumab is viral. So this is against the F protein of respiratory syncytial virus, and this is why we give this in prophylaxis of respiratory syncytial virus pneumonia, that is respiratory bronchiolitis in high risk babies. Cetuximab, tumor. So this blocks the EGFR gene, and that is why this can be used for CA colon, it can be used in CA lung. Yes, so TU again, trastuzumab, pertuzumab, we have just seen HER2 new inhibitor against breast CA. So this is how this is gonna help you. This is CI. So when CI comes, this must be something to do with the circulatory system. So what is CI? What is emicizumab? This is a new drug which is developed against hemophilia. It increases the hemophilia factor 8 and 9 levels. When you see KI, whenever KI comes into play, something to do with interleukins. These are interleukin inhibitors. So I and S, combine them. This is IL-17 inhibitors, Riza, Gucel and TIL. So R, G and T, these are IL-23 inhibitors. And ustekinumab, remember Ustad drug, it blocks both. So it blocks IL-12 in addition to IL-23 inhibitors. Alright, so this is how you remember both of these. Then when you see basiliximab, Li, meaning it has something to do with lymphocyte activation. So it's going to block the lymphocytes. So basiliximab is an immunosuppressant that is used in preventing transplant rejection. So this is an immunosuppressant. Li tells you it blocks lymphocyte. Eculizumab we have seen in hemat as well. This is a C5 inhibitor used in PNH. Natalizumab, this blocks alpha 4 integrin. Alright, and this is what we use in multiple sclerosis. So this is how you're gonna be helped. OS, do you remember denosumab? So this is for osteoporosis, bone related. BAC is when you have bacteria getting involved. Tox is when you have toxins. NE is neural. So all of your drugs with NE, remember, they are gonna be your migraine drugs. Yeah, so this is what we have seen, and this is gonna help you. And rest of the monoclonal antibodies we have covered in the respective systems. All right, and that's why I have not included here, because I want you to do them then and there. When you see this 20 to 30 drugs together, you're gonna mix everything up. That's why I've kept them in the independent systems, and that's how you're gonna revise them. So this marks the end of one of the most dreaded things for me to actually teach, which is pharmacology. It is not my strongest at all, but I hope that some good will come out of it. So thank you so much, and I'll see you all with the next one.